So, nobody can match Sushil Chauhan. You all agree? So, anybody who stands after him, before him, or with him, he'll be dwarfed. So, it doesn't matter what height you have, but the stature of Sushil Chauhan is unparalleled. And sometimes you don't remember the small incidents which you have spent with your colleague. So, I know it is difficult. I stay in West Delhi and I stay back in BLK hospital so that some distance was covered.
या फिर आगे माइक कल नहीं जाएगी
I am delighted to be here.
तो लाइट बंद करने को किसने कहा लाइट अगर बंद कर दो अभी नहीं अभी जब लाइट तब बंद कर दो चला दो अभी नीचे से
So whenever you feel bored by my academic talk, you can ask me to stop. I am going to mix this talk with certain cases which may not be true what I go. Even though Abbott brings me, and Abbott has been, before Abbott it was, Vertin was a product of Solvay actually. So talking about vertigo has been my passion since maybe 30 years. Since the time I joined neurology, maybe all over, and there is a CME which Michael Struck conducts when he comes to India. He is a guy who is totally dedicated to vertigo. So you should tell this guy to inform you so that you are there in that CME. Many things about clinical management of vertigo will learn. So this is my first slide. This is nothing to do with vertigo, but this is Sushil Chauhan. So what is this? Do you remember what this is? So he was working in Katra and he on telephone informed me that he is a patient of TBM who is having intractable seizure. But this calcification has to do with the seizures. This is nothing to do with vertigo, but I am telling you how our relations are built. So any medical college, particularly in MAMC, whenever you will see a rare case somewhere or some difficult case in the night even, then all the people on duty will be informed about this case. So I am informing you as if it is an emergency night and Sushil has called me. Actually Sushil did call me. This patient also belongs to some village to which he also belongs to, Palla Bhattavarpur. So this was the son of a policeman whose CT was, that time there was no WhatsApp, so I was told the report of a basal ganglia calcification. So it's a patient who is unconscious, who is admitted and who is having intractable seizure and whose seizures are not getting controlled with the diagnosis of TBM with seizure. So what it could be? So when Sushil transferred this patient to Jaipur Government Hospital, when he transferred this patient to Jaipur Government Hospital, I'm going to talk to you something you always feel guides you. So I'm driving from my hospital. Traffic was not so much. Jaipur was just 6 kilometers from my house. I was thinking what it is. So he has told me that patient has got basal ganglia calcification and intractable seizure. And patient age is 16 years. And the provisional diagnosis is TBM with status epilepticus. Anybody who wants to make it hypoparathyroidism. So this is my intern, So what is this case? So why I remember Sushil is, so when the patient reaches Jaipur Golden, I make a history. And the history was this boy who was 16 was operating for thyroid carcinoma at the age of 14 years, and this guy was having hypoparathyroidism and his seizure was nothing but hypocalcemia. And once I took the history, it is very difficult to stop all anti-epileptic when the patient is not conscious. It is very difficult to stop all ATD, but gradually this patient improved. There are two aspects to this diagnosis. You must ask the patient everything. You know, today is an era, patient hides so many things and he thinks they are not important because patients are better doctor than any doctor. So this history was a relevant thing which gave me a clue, but what I am thinking is correct. Today, of course, our investigations are faster. We do everything in a bigger hospital, but at that time, we were doing relevant investigation, and only thing I sent was calcium. In fact, I never got a PDS never done because I knew that it is a hypoparathyroidism, secondary to thyroidectomy. And once we started on vitamin D and calcium supplement, there is another important thing to learn from these cases. The vitamin D which you require is 125 dihydroxycholecalciferol because you don't require much, otherwise it has to be converted. So this patient was put on brocaltrol and a calcium supplement. Brocaltrol was the Roche only salt that used to come now, others also are there. Pediatrician will know it better. But there is another sad part to the story. Patient became alright, sent home conscious on brocaltrol and calcium, and they stopped the medicine. Once they stopped the medicine, the patient was again having those technique movement, going in to see the leg movement, admitted in the nursing home because Jaipur Golden nursing were on strike. So this patient we lost. But why I am showing this patient? More clinical situations, sometimes something drives you. So when he told me that the patient has basal ganglia calcification, when I was going to my hospital, one day I had this thought. So these are, and there are many such things. Today I practice neurology. Why I enjoy is, many of you who are my colleagues, we belong to an era when we did not have investigations. We did not have CT, we did not have MRI, we did not have ultrasound, we did not have echo. What we were taught and what we developed was the great clinical sense. We try to give importance to every symptom or sign which we are getting in this patient. So the only clue in this patient on way to hospital, if missed for few more days, patient will develop ventilator associated pneumonias and complications and we won't know what to do. So this is why I brought this case. It is not part of my routine talk, but it is also part of a resident thinking very judiciously that who will be the person whom I should refer this case, and he called me and referred this case to Jaipur. I didn't fail it, but patient's family as it is failed both of us and they stopped the when I am talking about I go for in today's era for a physician or for a neurologist or even for a GP, whenever the patient comes he tells you that I have got chakkar. And patient tells you of chakkar, and the moment patient tells you of chakkar, you prescribe a chakkar medicine. What you see in this CT is this MRI is a DW image, and you have got cerebellar infarct. If I tell you about this patient, the patient is a very high profile patient, and IPS officer, senior IPS officer, whole family is IPS officer, sister is an IPS officer, husband is an IPS. So you must understand what would be a position of doctor when they are examining this patient. So my take, all this area is more important the patient is, more important the VIP is, treat him like an ordinary person. So this patient went to RML hospital. Day before they came to BLK hospital. And the patient had a history of migraine, and they were telling that patient has migraine, and in migraine they get chakkar. So patient was sent to RML is a very prestigious hospital and all. They were giving my introduction. 2 years I spent in RML hospital because my number was low on that's the list. 11 people got to MAPSI and few got to RML. It was a part of Delhi University at that time. So there were 4 healthy seats.
When was this, sir?
80 to 82.
I was there.
I was Dr. Kittur's PG. Dr. Karoli was also there.
Yeah.
Dr. Chaube, who is a famous surgeon as a registrar. There are many stories we can talk about it if you are there. So this patient came to us next day, and this patient had a cerebellar stroke. We couldn't do thrombolysis because the plain images is already showing. So this is what we should take home from today is that every patient of vertigo doesn't need vertigo, even though it hurts. But what I am saying is every patient of vertigo doesn't need vertigo. And my lovable Dr. Tanzeel is here, who is my dear patient. Every day my stress is that listen to the patient. Patient is telling you the story. Listen to the patient. So before I proceed further, I will tell you one difference is there between peripheral and central vertigo. Today is an era of activism. If I miss a central vertigo, I am committing a crime. That is what it is. We have our legal aid. But if I miss a peripheral vertigo, it doesn't matter. So if I am giving vertin and vertin and vertin to everybody who gets, and patient also eats. So my job is to be able to decide. Don't go into ethics whether I should get an MRI done. If doubt, get it done. Because even if you have got an extra MRI done, doesn't matter. But if you have not got it done and there is a stroke, so this patient had all the high-ups lined up for the treatment, but patient MRI was not done and patient was sent home. What were the clues? So I am going to tell you again in the beginning, you have to differentiate between central and peripheral vertigo. That is the only job you should learn. Few clinical points and few examination points. So a patient of peripheral vertigo shall be able to walk even with difficulty. But a patient of central vertigo will not be able to walk. So if your patient can, so make the patient walk. This is not the first time. I have committed this mistake earlier also. I will show you another case. I have committed a mistake where the patient turned out to be a cerebral stroke 3 days later, but patient was complaining only of chakkar. So chakkar is a serious thing. And it is one of the, anybody from ENT, it is one of the commonest symptom after headache presenting to GP.
Sir, Dr. MPS Gandhi.
He also from me.
So, you get chakkar is a very common symptom. And GPs, specialists, ENT, physicians, we all get chakkar. But chakkar may mean even epileptic fit, because people are not ready to say that मेरे patient को दौरा आता है, they will say chakkar आता है. So the important point I want to say is, I will not be able to complete my slides if time is up, you tell me. The important point I want to communicate is, dissect the symptom. Dissect the symptom. Every symptom has to be dissected to be able to conclude it into a anatomical and a physiological localization. First, a physiological localization. If my patient says chakkar, I must know what this chakkar means in terms of physiology. And once I am sure of physiology, I know where the anatomy is faulty. This is what is expected of me, and this is what to some extent you can also do. But at least if the patient is not behaving like a conventional patient, in that patient you can probe it further and tell that it is good. I am not able to display a song because my computer has been changed. But the best management of chakkar is by that song, Sar Jo Tera Chakkar Dil Dooba Jaye, Aaja Pyare. So that's a chakkar management by repositioning. You know, if you shake the head and then ask the patient to put into a different position, that is actually a song which tells you what should be done in a case of benign paroxysmal positional vertigo. So, but we are not playing it because that my laptop was not compatible with this. So what we are going to do is pitfalls in diagnosis of vertigo. I will again focus on some cases. I will omit the theory which is available to all of us. And what this experiential learning means, so we were talking about empowering doctors to empower for the health of India. So once I was in a conference, DNA Con, so the conference finishes at 5 o'clock and the dinner starts at 7:30 in India Habitat Center. So there was one session in the dining hall which was going on as experiential yoga. So I entered into that hall and learned how, that is, you experience from cases is to be discussed to learn about vertigo. So this is what it means. And this is what I highlighted right in the beginning. Patient who presents with a new insight, severe dizziness, imbalance and nausea and vomiting are challenging patient because serious neurological causes such as brainstem and cerebral stroke must be considered. So that was a learning from that case which is highlighted. This is from a journal which comes in clinical neurology in green neurology by American Academy of Neurology. So this is the what I want you, even if you don't listen anything but read this, keep it in your mind whenever you see a patient of diabetes. Because most of them will settle by their own, but some of them who don't settle by their own require special attention to their symptom by all of you. So this is another case, known case of hypertension, old cerebrovascular accident 2017. So this patient, why it is important today? You know, maybe 20 years back it was not important even if I missed a stroke because I was not supposed to do anything except taking aspirin for secondary prevention. Today that stroke can be reversed. So you have thrombolytic effects. So you have to identify vascular cause. So see this patient. So this patient had rapid deterioration, came to our casualty and she was ventilated right there in emergency. CT brain showed movement artifact which were limiting the study and MRI screening showed acute infarcts in the posterior circulation territory. All these areas are mentioned and this is showing. This all whites are DW imaging and this is showing that the patient has infarct. So mind you, this patient also presented as chakkar and the chakkar went on to intubate the patient and the patient is in our casualty. So why we should be worried about chakkar is, this is what we found in MRI angiography, the basilar artery is blocked. So now the basilar artery is blocked, I called my interventional neurologist and he says nothing can be done, patient was already on ventilator. But you keep on thinking, can we do something? Once he refused that he can't do anything, I gave connecting place to this patient. So, we will not discuss in detail, but post-connecting place, just see, intravenous thrombolysis was performed, next post-thrombolysis NIHS was 7, shifted to room after 1 day, started over fees after 3 days, ambulatory with support by 3 days, discharge after 4 days. And what I want to show you, just see this basilar artery. This is totally opened up. So, never say it is too late and never lose the hope. Keep on trying whatever you can give, but you will only give it when you think the chakkar is not merely working related chakkar, it is something else. So, that is why it has become even today more important. Earlier we did not have facilities to be able to see this basilar is totally cannulated. So this patient had total recanalization and if we are able to reverse or so what do you do in stroke? In stroke you do two things. You restore the circulation. If you restore the circulation you are able to salvage the penumbra. So patient practically had a salvageable penumbra. Now it is we can do perfusion study to actually find out. But I took a chance and gave it and the patient was benefited. So this is what it is. So what is vertigo? So vertigo is an illusion of movement. So this is the true vertigo whenever a patient has an illusion of movement, actually there is no movement. A sensation of turning, hallucination of movement, unpleasant disturbance of spatial orientation, illusory perception of a movement of the body and of the surrounding. So you always ask the person whether there is a sense of rotation of self or surrounding. And it is a subjective sense of imbalance, rotatory vertigo if it is spinning. So whenever patient will call chakkar anything, the fainting is chakkar, lightheadedness is chakkar, postural hypotension is chakkar and claustrophobia is also chakkar. So patient complains of dizziness. Does the patient have a true vertigo? As I told you, the true vertigo is whenever does the room spin or knee spin. Room spin or knee spin. So it is an illusion of vertigo. So what is the next? Do you feel unsteady? If you feel unsteady, it is disequilibrium. And unsteadiness people feel when they have other balancing problems. So that is not true vertigo. And most of the time it may be neuropathy when we know that the posterior column which gives us a sensation of balance, it may be musculoskeletal weakness or peripheral vestibular disorder. You must ask the patient whether your legs are giving away or whether there is a visual obscuration. This is a pre-symptom, and if you want to really learn about it, next time record a child who is brought to you by parents of having had loss of consciousness standing in the prayer for a long period of time. That child will give you exact history what was happening. Record it and remember every time to ask another patient whether it is this sensation. Lightheadedness is another non-specific sensation which may be any one of them, but it may be because of anxiety, it may be because of anemia, it may be because of many other systemic factors. So the true vertigo has to be differentiated from other things. How does vertigo happen? So we have a very intricate balancing system. So there is an input to the brain to make us aware of our balance, and that input comes from the vestibular system, visual symptoms and somatosensory. Like if I am standing here, suddenly if you sometimes you feel that there is a step and it is not there, you feel a balance. So whenever these things are in mismatch, so sometimes patient who develops sudden ocular problem also may complain of chakra. Patient who develops sudden posterior column sensation also may complain of chakra. So this has to be differentiated from pathological causes or physiological causes. So you must understand how we achieve balance. And any alteration in balance in any of the system which is giving you a spatial sense of balance is going to be causing you chakra. So there is an input and there is an integration of this input in the central nervous system to the pathways which goes to the spinal cord, brainstem, ocular system and finally to the brain. And that is how we achieve a sensation of balance. You can see this ballerina. How we recover from imbalance is if you use your system. So the treatment of vertigo is not resting. Treatment of vertigo is challenging your system again and again so that there are remodeling of the circuits which are lost. So we must know why the imbalance occurs, and if we have to challenge this imbalance for making balance, then you have to use this. So this is how you can see you can stand on one leg. Incidentally, if you can stand on one leg for 30 seconds without eye closed, if you can stand for 30 seconds with eye closed, then your actual age is less than 30. So it's a difficult thing. And on one side you have central disorder which causes imbalance, and on the other side you have peripheral disorder which causes imbalance. In central disorder, neurodegeneration, but what I am thinking and what I want all of us to remember is in acute cases we must not forget about the stroke. In peripheral disorder, one of the commonest disorder is benign paroxysmal positional vertigo, but otherwise labyrinthitis, mania subtilis, paralysis and vestibular neuritis. All of them have specific features. If there is time, I will talk to you. But otherwise, each one of them requires a philosophy. So I presume most of us know about it, but you must have one or 2 points. Like vestibular neuritis will be like trigeminal neuralgia. There will be paroxysmal vertigo. And like trigeminal neuralgia, we treat with anti-epileptic drugs, so we can treat vestibular neuritis. But viral vestibular neuritis will require a steroid to be treated. So that's like an autoimmune reaction like facial narcolepsy. So what are the symptoms? So there are 2 things in medicine almost all of us should be able to do efficiently. One thing is we should be able to manage patients well, symptoms well. So my patient he doesn't bother about that moment and how great doctor you are and what diagnosis you make, but he wants you to make him better. So the most important symptom patient complains is vomiting, anxiety, nausea. So what are the important drugs? So I tell you, in my practice, I use chlorperazine, statin even today. And if my patient is not able to tolerate oral mouth dissolving formula, I will give an IV 12.5 milligram 8 hourly for first 24 hours. Most of my patient become better. If my patient can take oral, so I give other 17 MD. They also had a drug, Ecubert. They are not voting nowadays. That is also, so mouth dissolving certain or intravenous. And it's my emergency drug in my bag all the time whenever I travel. So this is still a useful drug. Otherwise, patient is very anxious. So sometimes, even to prevent EPS, extrapiramidal side effect, I combine Stametil with clonazepam mouth dissolving. So in a clinic, when patient is not too bad, you can give that. So you have to target your immediate medication to control the symptom the patient is having. This is how to differentiate between peripheral and central. I think the most important difference is the peripheral one, patient can still find a posture, a position to make himself comfortable. In central there is nothing like that. In peripheral, suppose patient turns and vertigo comes, if he remains in that situation, the vertigo will go away in 30 seconds. In benign paroxysmal vertigo. But the central one and the other symptom is, in central you will have associated symptoms. You will not have pure vertigo, there will be associated symptoms. So that is how you have to find it out. This is again like the first slide. Patient complains of dizziness. Does the patient have a true vertigo? If the patient, so I will show you a case also. It is very important to find out whether the patient is taking a drug or not. If he is taking a drug, trying to find out whether that can cause vertigo or not. Then continue to take more history and obtain the history of the duration of vertigo. Perform head and neck and cardiovascular examination. If that is negative, then perform neurological examination. Why I am saying you should know the postural technique. So I used to go as a visiting consultant to Rajiv Anand Cancer Institute, and there whatever referral I used to get were postural hypertension in a patient who is on chemotherapy and diabetes. So that is a very important issue. You make your patient's blood pressure in lying down and standing position, and if there is a significant fall, more than 20 systolic, then you know that it is not vertigo, it is a postural dizziness. And neurological examination of course is coming at the end, but if my patient is coming to my OPD only, I ask him to do finger nose test, I make him a tandem walk, so that can help you. If you are getting purely localizing symptoms which are not fatiguing, then probably you are dealing with the symptom. So this is the most important few slides I am going to show. I will finish before time. So these are the cases which I am going to show, and these are real life cases, they are not the same. So spontaneous and gaze involved mixed segments, this is you have to see. Bedside vestibulo-ocular reflex assessment, you have to see. Positional testing, gait and balance testing. So this is, if you are accustomed to do it, you can do it in 5 minutes. So what are the red flags? The red flags are either there are symptoms which are persistent without fluctuations, and there are added signs and symptoms. As when I showed you the first case, we were not great. Since our patients were persisting with symptoms for more than 24 hours, she was not able to stand at all, and she had very difficulty in keeping both eyes open. She had visual oculomotor dysmetria, which were making her very uncomfortable when she was keeping both eyes open. Either she will look like this or she will look like this. So there is nothing great we did, and we have the facility of doing an MRI, and within minutes we did an MRI. So if you have persistent symptoms without fluctuation, peripheral vertigo invariably tends to fluctuate, then you should do imaging. These are some real life patients. As I told you, take a drug history. This is a true case. An epileptic patient which had falls preceded by chakra. It was taken query seizure, increased anti-epileptic drugs and vestibular sedatives, vertigo increased further. Then the patient comes to me and do the drug levels. Patient was having toxic antiepileptic drugs and we decreased the antiepileptic drug and patient improved. So this is what the importance of clinical medicine is. Actually it should come in a and if that drug can cause vertigo, you should be able to find out whether it is a toxicity. So neither the patient was having vertigo nor patient was having ataxia and some imbalance. So that is what you get in a antiepileptic drug toxicity, but actually you have to decrease the drug. So first they added the anti-vertiginous medicine, after which they must have given a sedative medicine. One good point about beta-histine is that it's not a sedative medicine. So it does not cause increase in sedation, so you can give it. But here when they gave the medicine, patient worsened further and more false clinician thought, it was not clinician, actually it was a neurologist who thought that it is seizure increasing, may he increase the dose further and patient worsened further. And when you look at proper history and clinical examination, you know that. Actually, I was in GP only, and if you remember, in 87 to 89, only MRI was available in mass. So when the MRI was available in mass, my own brother had vertigo. So I ordered for an MRI, and when MRI was negative, my own classmate, Dr. Rajiv Anand, an ENT guy, I showed it to him, he removed the bags and patient became better. So this was my own brother. So when we have an investigation available, that is what we do. So these are all real life cases. Actually, they should have come in a cascade so it makes more interesting, but this way also, it gives you the point and save the time. So this is another case. So this is a case, I don't know whether, I don't remember Sushi's association with this case, but this was also one of my first cases when I ventured into practice and I went to Kahara nursing. This is like that elephant I should have shown you. Everybody looks at elephant from his own viewpoint. So this patient was having vertigo, ENT consultation was taking and drugs were prescribed. Then person with just nothing but the vomiting and no other than my great teacher at the department, ex-HOD, and even today he is 90 plus, Dr. P.S. Gupta, he was brought to see this patient. And he did endoscopy, and today also everybody will come and do endoscopy and say you that it is a gastritis. Since the patient was patient was घबराहट, sweating, for which a cardiology consultation was taken because it was autonomic symptoms. There was no relief. One of my first patient, I was called, and that was little medullary syndrome. So you can see the MRI, you can see the little medullary syndrome. So this is today's common problem. We are not seeing elephant as a full. We are seeing parts of the elephant, and we all of us do it. And in fact, today's super specialists are doing it more often without a basic grounding in general medicine or a general, you can say whatever it is. If you are just focusing on the symptom which belong to your system of specialization, you are going to see either part of the elephant. You may see its eyes. So this is a real life case. This is another patient. So neck pain, doctor was consulting, X-ray cervical done, cervical spondylosis. Which is just been diagnosis as far as concerned. Traction was given, physiotherapy was done, no relief, and then watch my test. So for us, actually we really order X-ray. Our neurosurgeon colleagues still order before going for surgery to see the mobility. So that doesn't work. This is another patient, occipital pain with chakra, given drug, but actually when you do a scan, you find a posterior fossa tumor. I'm not saying every patient, these are rare cases, but I do get these cases. This is also very interesting patient. If you get a patient with chakra, here the temporal if those of us you were introduced to UCMS. So you had a UCMS couple who were in Daryaganj and the husband had herpes simplex encephalitis and he had memory loss. So wife, I don't know the name, but the wife was left to look after him. So if somebody knows him, I was in month at 87 to 89. So this guy had a fever, memory loss, and that time it was not very aggressive. I will not say that whatever I have learned is from my government institution. Either by nature or by demand of the public, we are more aggressive in pushing to a diagnostic conclusion in private institution. I'm not saying. Like within 24 hours, if we don't find the answer, we might even do a PET. So this patient, now I don't see herpes simplex encephalitis going into permanent temporal lobe damage and memory disturbance. This doctor not only became dependent because he ceased to be a doctor when he had a herpes simplex encephalitis because it was not diagnosed. So any patient coming with chakkar and some behavioral disturbance and some viral illness, it is not vestibular neuritis, it may be herpes also. So this is a herpes simplex encephalitis that temporal lobe is involved. This is another common scenario. Patient may be walking, patient may be going around, young girl, telling you that I am feeling some dizziness, I am feeling some sensation, and it is multiple sclerosis. These are the plaques you see. Rare, but we must know this. And this is another patient who has a cerebellar hemorrhage. I told you earlier of a cerebellar stroke. This also may present to you like a chakra. So this is a Berkey scale. You can access it. I gave a lecture. This lecture is close from Vertigo lecture which I gave in API, which was held in Bharat Mandapam in Delhi. Many of you may have attended. It was a grand. I liked it. And there this Berkey scale was introduced. These guys can give you booklets. If you use it, you will be able to differentiate between what are the most of the patients, what are the causes of okay. So this is a vertigo scale, and I think I have finished.
Sir, please sit there. Please come here. लाइट जला देंगे विजय चलाओ वो जरा घर चला दो सर प्लीज कम हियर What a wonderful deliberation by my guru, my teacher, Dr. Rajiv Anand sir. सर जितने शरीफ लगते हैं ना उतने शरीफ है नहीं, बहुत जोर से डांटते हैं, मैं सही बता रहा हूँ. I was only afraid of him in GB Punch when I was doing my half job and even in my practice. But sir gave very clear directions in every single case. We collaborated on many cases for neurology. Sir showed me the way. मैं आप लोगों को एक गाना सुनाना चाहता हूँ before we venture into question answer session. Dr. Bimal, जल्दी आ जाना. Yeah, I know. I can see your little finger. What it means? Solifenacin is another answer to your question. But that is not the topic. Can we hear that, please? सर ने बोला कि every vertigo does not mean vertigo, and I happen to refer a case to sir, which sir related.
तेरा चकराए या दिल डूबा जाए आजा प्यारे पास हमारे काहे घबराए सल तो तेरा चकराए या दिल डूबा जाए आजा प्यारे पास हमारे काहे घबराए जिसके सर पर हाथ फिरा दूं चमके किस्मत उसकी तेल मेरा है मुस्की गंज रहे ना खुशकी जिसके सर पर हाथ फिरा दूं चमके किस्मत उसकी सुन 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 अरे बेटा सुन इस चंपी में बड़े बड़े गुण सुन 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 अरे बेटा एक दवा है क्यों ना आजमाए।
सुन सुन सुन, अरे बेटा सुन, इस वर्ड टीम में बड़े बड़े गुण, लाख दुखों की एक दवा है क्यों ना आजमाए। जो भैया मेरी बात सुनो, 60 साल पहले जोनी वाकर ने कहा कि वर्ल्टिन जो है ना बहुत अच्छी दवाई, उसने नाम नहीं लिया। आप सुनो, सुन सुन सुन, अरे बेटा सुन, इस वर्ल्टिन में बड़े बड़े गुण, ठीक है। तब वर्ल्टिन पता नहीं थी कि नहीं थी। डॉक्टर राजीव आनंद सर शायद एमबीबीएस कर रहे थे और हम तो पैदा ही नहीं हुए थे। So I would request all of you to please have some questions, relevant questions. And the first question that we have is from Dr. Sarath Gopalan, President, Nutritional Society of India, Nutritional Society of India, whose father was Director General ICMR. Dr. Sarath Gopalan happened to be my intern in Sabdajana.
Sir, my question is not a question for me at all. I am asking you this thing as a layman. I want to congratulate you for a wonderful presentation today. It was a fantastic presentation. But I am a pediatric gastroenterologist. I understand nothing about neurology or ENT. But I think it's important we have interactions from adult and pediatric backgrounds when it comes to neurology. So I would invite from the standpoint, Dr. Tulsi is right here. His questions, Dr. Gandhi, who's an ENT person in adult, for questions. Dr. Ashok Chakravarti, is there now? Are phone pen. Okay. Dr. Ashok Chakravarti, Dr. Sunil Sehgal, is he here? No. Okay. And Dr. Anand was here for the presentation. Is he also here?
He is here.
Oh, okay. Sir, so adult and pediatric inputs when it comes to vertigo in children and adults, both neurological perspectives and ENT perspectives. Thank you.
Sir Bhaskar, any difference in what I know in children and adults? Is it to be viewed differently and investigated differently? And your investigation statement different in children versus adults?
So first is, as I told you, the management has to be holistic. And the whole world is today talking about gut-brain axis. So we cannot be isolated in terms of that pediatric gastroenterologists will not have this problem. In fact, in children, the manifestations of vertigo and migraine are often accompanied by abdominal symptoms. I have had patients, I'm not talking about vertigo per se, but I have had patients whom we have diagnosed cyclical vomiting as a migraine phenomenon. We may not call them abdominal migraine. Similarly, what is more common in children? Of course, today we have pediatric neurologists who have come into the practice, but my first 20 years of practice, there were no pediatric neurologists, so we were seeing children also. So what we see in children is, there is very common phenomena, if pediatricians are here, they get very transitory vertigo. They will just stop their activity and they will just hold on to something and then they will start working. And these attacks are more frequent. It is not like adult vertigo. And the children cannot tell you what it means. You cannot, it depends on the age of the children. Once they are, say, past 10 years or 11 years, I don't consider them different from what adults are, but for actually pediatric age group, even 2-3 years old toddlers, they get small, short-lasting vertiginous attack, which actually we treat like migraine, which we don't treat, and they require different management. So children are not included in most of my presentation which I have given. If other pediatricians have to contribute, I will learn from them. My colleague first gives in.
I think Dr. Bhaskar Shukla being the MD Pediatrics and DM Neurology and also being MD Pathology. Sir, ये राती और कर लेते हैं. No, sir, I mean no jokes, but I mean great effort from Dr. Bhaskar Shukla to have done his MD Pediatrics, MD Pathology, and then DM Neurology. Proud of you, proud of you. Sir, whatever Dr. Rajiv Anand said, what is your opinion to that?
So wonderful talk. I thoroughly enjoyed the talk and I was listening very carefully to each and every word you were saying and I thoroughly enjoyed the talk. I learned a lot. I always look forward to listen to your talks in future also. So wonderful talk for the first day. So I have a few comments to make.
Dr. Bhaskar Shukla, I would like to especially like to have your opinion vertigo in children versus adults.
So, as sir said, that properly expressing the problems also is a problem in children, as we all can understand. Children below 5 years of age especially, or 8 years of age, 5 to 8 years of age, they may not be explicitly able to tell what they are feeling. So, it is often the parents who tell, and it might be their own imagination, which might not be true, what the children are actually feeling. So it's very difficult to substantiate whether the children are having vertigo. It's very difficult to actually document the true incidence of true vertigo in children in that age group. However, migraine being very common, in fact, the most common cause of headache in pediatric population is migraine. We must all know. And vertigo can be part of the migraine, as we know it, vestibular migraine. So vestibular, if the children are able to express, there are many children who are smart enough, who are, especially advanced for their age, and especially children who are like 9 years or 10 years of age, they are able to experience and they are able to communicate. I think vestibular migraine seems to be the commonest cause of vertigo in pediatric age.
We have Dr. M.S. Gandhi sir, who was HOD of ENT and Charak Palika Hospital, also the CEO of Charak Palika Hospital. I would like to have your comment on that.
It was a very nice lecture, and my all compliments to Dr. Anand. In fact, as far as ENT is concerned, we have come across ENT cases, and there we are very frequently doing PTA and other tests also which are required for ENT cases. And vertigo, vomiting, and in Meniere's disease specifically, we come across cases and that can be diagnosed when we perform other ENT tests like VNG and what do you call this PTA. They are vomiting, vertigo, deafness and tinnitus. Tinnitus is also one feature which we come across in many ENT cases, and that is diagnosed by, most of the cases are diagnosed by proper clinical assessment and few tests by which we are able to find out the exact ENT causes, whatever it is there. In fact, I have come to, in fact, one patient came to me who was having vertigo as well as he was having some kind of a deafness which increased gradually, but he ignored it. It was a young patient. And later on when we examined it, it came out to me there are a lot of wax in it. Once we removed the wax, it was a cholesterol. And that patient ended up with facial paralysis also later on after the surgery. So these were few cases which were, in fact, he only ignored, the patient only ignored it because he came very late to the surgery. So that was the thing.
Thank you. Sir, any comment? Dr. Anand sir?
Welcome input.
All right, Dr. Luthia sir. I was pleasant, it was a very pleasant news. Dr. Luthia sir is a fellow Monalian I never knew that, sir. I want to argue for that.
Asking a question from my first teacher when I entered clinical medicine. In case of my differentiation of peripheral vertigo versus central vertigo, one of the clues I was taught was vertical nystagmus versus sidewise nystagmus. That generally gives a clue that there is a central cause or not. That I stand to correction from a neurologist. Number two, you said patient needs to be relieved of his symptom first. Symptoms first. The commonest symptom is instability, vertigo, spinning, and vomiting. So, Slimetal that you suggested was a good choice, but we also use Strugeron Plus, that basically Cinarizine and dimenadine. And it's a mouth dissolving tablet, and sometimes works in terms of controlling the symptoms. And the third question I want to ask is, the maneuver that you suggest that a person of vertigo can be done at the case of during acute vertigo to correct it. Thank you.
Starting from third, so I think there are two maneuvers. I commonly use Siemens maneuver, but I will not go into details of it. You can Google it. But you have to be sure that you are dealing with a benign paroxysmal positional vertigo. There the treatment is not verting or Strugeron. I will take it as an input and a personal experience. We have gathered here to benefit each other. So Lutri has commented that he finds Strugeron Plus useful during those conditions. Is correct because in clinic, but we do not have an intravenous form, so we are, in fact, this patient of cerebral stroke, we are giving 12.5 milligram of prochlorperazine IV 3 times a day. All drugs can have side effects, but if you are tuned to knowing that this patient can have that side effect, you can use, like even during my undergraduate days, Dr. M.P. Gupta, we were taught that beta blocker should not be given to diabetic. But he says if you know what it can do, you can give it. So now we do give when we are required to give. So both your comments are okay, but maneuvers are go-go thing. But first day when patient comes to casualty, actually all good patients don't come to us, they go to you. And those who are going to be, because when the patient is too symptomatic, then for first 24 or 48 hours I can't do maneuver. Because if you immediately start doing maneuver, patient will vomit it at your face also. So that is why I say whatever symptoms you are getting, you control that symptom. If patient cooperates, you can do the maneuver. In case your diagnosis is benign paroxysmal positional vertigo. And we have not talked what will distinguish benign paroxysmal positional vertigo from vestibular paroxysmia, Meniere's disease, neuritis. But subsequently, if you need, we can talk specifically, please talk. And what was your first?
Central vertigo versus peripheral. Vertical nystagmus.
So nystagmus is central vertigo and peripheral. So you try to understand that unidirectional nystagmus is not peripheral. Peripheral nystagmus has a rotary component. It is like this. So if you have a pure vertical nystagmus, it is central. So if you are able to separate pure horizontal from horizontal with a rotary component. Another point of nystagmus is nystagmus in peripheral vertigo will fatigue out. Like if you constantly ask the patient to look in one direction and you see nystagmus, it will go away. In peripheral, in central it will not.
Coming to some important questions, sir. Dr. Sunil Kapoor, sir, a fellow Molanian, 2 years senior to me. I love you, sir.
Oh, sure. It's a delight and a pleasure.
It's mutual.
Sir, I'm 2-3 years younger. I'm also a Molanian. It's a delight to have you. I have two semi-serious questions. One is, I do a lot of horrible tests in my clinic. How much is the relevance of that? And secondly, it's a nitty-gritty talk, मेरी गर्दन में वो है, मुझे cervical है, so what I was found out is this is of more than 50% is the basic for this thing. So what should this cervical level above which this is relevant?
In context of vertigo, cervical spondylosis has no meaning. So cervical, actually, what is cervical spondylosis? So you see some bony changes in the cervical spine and you call it spondylitis. Your patient comes with vertigo, you get an X-ray cervical spine done, and you see those bony changes. Patient is happy, doctor is happy. It is an easy way out of a situation today when patient is asking you what is the cause. But let me ask you, when this patient's vertigo has got remitted, vertigo is remitted, will that bone disappear? The bone will still remain there. And if you all remember, a spotter which you were given in MBBS and MD was a rib being, not cervical rib, a rib in the chest getting eroded by a pulsatile vessel. So people think that cervical vertigo is because it is impinging on vessel. A pulsatile vessel will erode the bone. So this is what we have been taught. So it is, I choose the word, it is a dustbin diagnosis. Don't make cervical spondylosis as a cause of paroxysmal vertigo. Person को कॉलर लगा देते हैं. There is no relation of what you are talking. So try to establish a relation.
Dr. Sunil
Impact test is a good diagnostic maneuver.
Dr. Sunil Kapoor sir asked a very important question, and sir has answered. Please do not attribute vertigo to cervical spondylosis. That's the message. Look
That's what I showed you, a port spine case.
Yes, sir. Sir, two academic pillars of the forum, Dr. J.P. Tulsi sir and Dr. M.L. Kalra sir. I will go to Dr. J.P. Tulsi sir. He is going to ask you some difficult questions. He is going to remind you of your DM examination, sir.
Every day we are going through exam, and when I tend to not answer not able to answer my patient, I tell him that मतलब like you, what they will tell you is कि मेरे फलाने रिश्तेदार ने ये बोला है डॉक्टर, इसका क्या मतलब होता है? तो मैं बोलता हूँ कि उस रिश्तेदार ने कौन सी यूनिवर्सिटी से डीएम की हुई है. Sometimes you have to assert, you have to say that I will not indulge, but not for you. I am ready for your question.
So, Dr. Rajiv, Dr. Chauhan was just kidding. See, we're talking about vertigo, and let's differentiate between vertigo versus dizziness. So, vertigo is a specific type of dizziness and defined as probably spinning or rotatory sensations. See, as compared to the dizziness, which is vague and non-specific. And recent studies, have indicated that CVDs do not cause true vertigo. They cause dizziness. And the commonest cause of dizziness in CVD is hypotension. Hypertension due to various causes. So it could be postural, as Manu said, and various other causes. So tell us, Dr. Rajiv Anand, the most common CNS cause of dizziness is this vestibular migraine. The most commonest cause, central cause of dizziness. Is it vestibular migraine, sir?
Is it a question or a comment?
Either way.
No. So I think we should be alert to the possibility of vestibular migraine, but that cannot be
the commonest cause.
But that cannot be the commonest cause. Vestibular migraine is just 3% of the total migraine, whereas pure vertigo, peripheral vertigo, as it is more common than this thing. Vestibular migraine, as my colleague told you, you should suspect in children also, because as I was telling that most of the time, when children will come, the mother only gives history and they suddenly stop. They are not able to believe when this child says to the chakkar aata hai. So I think it is not commonest, but even if it is not commonest, it is an important test.
And the patient who has the other causes of vertigo.
We are talking about central cause.
Central cause.
Not central. Is this the vestibular migraine seems to be the most important and most frequent cause of central vertigo, not peripheral vertigo.
Sir, in vestibular migraine we can have other symptoms also.
I know, but this seems to be the commonest cause. Okay, let me proceed further and talk about the posterior fossa strokes. You see, which is the most urgent etiology, in acute vestibular syndrome, and the commonest symptoms is dizziness, hearing loss, headaches, and it carries a significant morbidity and mortality. So we're talking about posterior strokes, posterior fossa strokes, and the imaging of choice here would be not a CT but an MRI, because ischemic strokes would probably reflect more here than on a CT. Talk us about that, sir.
Yeah, you're right.
Okay, sir, great. So, finally, Dr. Rajiv, let me ask you a very personal question to both of you. Prochlorperazine versus cinnarizine and diphenhydramine and beta-histine. What is the drug of choice you give here? Forget about our post today. So, which is most important here? Is it beta-histine in acute cases, or cinnarizine, a combination of diphenhydramine or prochlorperazine? Tell us, sir.
I am already told that my in acute vertiginous condition with vomiting, my choice is prochlorperazine, and during maintenance phase, I will give beta-histine because it's a non-sedative, and the sedative drug hamper recovery. However, I will not disagree with Dr. Rajkumar also, where he used a combination of other things. So you have to, so today is an era of customized treatment. So my colleague is sitting, so we say you must know the mechanism of symptom. If you know the mechanism of symptom, then you also must know the mechanism of drug which you are giving. If you spend time on these two factors, you will be better than, you will be smarter than your colleague. So situation demands prochlorperazine when patient is actually vomiting. So you can hit two birds with one stone, because patient is vomiting, patient has the vertigo, and patient is anxious also.
Yeah, there are 3 parts.
So, in an era when my senior is there, my junior, when like I was an intern in my house surgeon, in casualty in a patient of breathlessness, we used to give Largectil at that time. And he used to tell me what are the benefits of Largectil. So, chlorpromazine. So, nowadays we don't use that, but something like that. A prochlorperazine, if you are aware of extrapyramidal side effect, is my drug for the very acute situation. But in clinics, since you are sending the patient back home, probably you may avoid prochlorperazine in favor of other drugs, which are modern drugs, may have less side effect. So you have to customize the medication according to the emergency you are facing and individual patient you are seeing.
Dr. Rajiv Anand, you answered this question wonderfully well. My last 2 questions will be regarding vestibular rehabilitation. We talked about vestibular suppressants. Let's talk about vestibular rehabilitations and the CRP.
So I think I appreciate that you have already told it is my last question. Otherwise, probably both of us will be using dizziness in our colleagues who are being deprived of dinner. And few more drinks in
Thank you.
So and invariably, I am now putting a word across to Sushil Chauhan that the rest of the discussion can go on paid for food.